Welcome to week 2 of Health Promotions. This week we're going to talk about the beginnings of life. The beginnings of life include conception, genetics, fetal development, and physiology of pregnancy. Here we're just going to review a little bit of the female and male anatomy. I'm actually just going to refer you to your book. On page 203 you'll see the external female reproductive organs. You can see here we have the clitoris, the urinary meatus, and the vaginal introitus, the internal female reproductive organs, the mid-sagittal view. The part I really want to point out to you here is you can see the cervical opening if you look at the uterus and towards the vagina. You can see the parts labeled on page 205 and figure 11.3. I want you to be aware of what the cervix is, that the cervix is kind of like a doorway to your uterus. Structures of the bony pelvis, the lateral anterior views. This is also something that will become important when we start talking about labor and delivery and the birthing process itself. Here you can see the muscles of the female pelvic floor. These are the muscles that become important when it comes to, one, pushing during childbirth, and also during that postpartum period when we talk about wanting to strengthen that pelvic floor to improve bladder function. Part of the female reproductive cycle is that anterior pituitary and the ovarian hormones. You can see on page 208 a labeled diagram of this. And we're also going to talk a little bit about the menstrual cycle and ovarian cycle, which is affected by these pituitary and ovarian hormones. Structures of the female breast. Here we have the structures of the male reproductive system in the mid-sagittal view. That is on page 211 of McKinney. The menstrual cycle. So the menstrual cycle is influenced by the pituitary and by the ovaries. The pituitary gland is what produces the follicle-stimulating hormones and matures the ovum. The luteinizing hormones, or you'll hear us refer to them as LH. LH maintains the uterine lining in anticipation of the implantation of the fertilized ovum. So both of these hormones are very important during those reproductive years. The menstrual cycle is influenced by estrogen and progesterone. The estrogen will prepare the uterine lining for implantation of the fertilized ovum, and the progesterone maintains the uterine lining for the implantation of the fertilized ovum. The female reproductive cycle. The reproductive cycle is the regular recurrent changes in the anterior pituitary secretions, ovaries, and the uterine endometrium. It's designed specifically to prepare your body for pregnancy. The female reproductive cycle is often called the menstrual cycle because menstruation provides the marker for each cycle's first day. So the first day that you see menstrual bleeding will be counted as the first day of a woman's cycle. The menstrual cycle. If conception fails to occur, that thickened uterine lining that has thickened to support a pregnancy for that implantation to occur, that lining will slough off, and that is what's considered the menstrual cycle. It repeats in anticipation of conception. The typical cycle is 28 days and is approximately 50 mLs of blood, and you can have mild or moderate cramping. Meiosis is the process of cell division which occurs in the maturation of the sperm and ova. This is when we decrease from the number of chromosomes from 46 to 23. Here is an example of what occurs during the meiosis process. You can see on the right, figure A on our screen is the formation of a mature sperm. If you look at the figures on page 214 of your textbook, you'll notice that those figures are reversed. It's figure B on page 214. Figure B on our screen, which is figure A in your book, you do see the formation of a mature ovum. Fertilization. Fertilization occurs when a sperm moves toward the ovum using its flagellum, and you can see that we have 22 chromosomes from dad plus 1 sex chromosome, and then we have 22 chromosomes from mom plus one sex chromosome. Now we know that mom is going to give us an X chromosome. And we know that dad is going to give us either an X or a Y. So that will decide if we have a male or a female. The figure on our screen, you can see the top one. We have the male sperm has given us a Y chromosome. So we are going to have a male baby. And we have an X chromosome on our A figure, which gives us our female. Fertilization. In this figure, you can see the process of fertilization. We have the sperm entering the ovum, which you can see on the left side of your screen. The 23 chromosomes from the sperm will mingle with the 23 chromosomes from the ovum, and this will restore us with our diploid number of 46 chromosomes. The fertilized ovum, now called the zygote, is ready for its first mitotic cell division. You can see the process of fertilization on page 216. Mitosis is the process of replication of like daughter cells. So now there are 46 chromosomes, 44 of them are autosomes, and 2 of them are sex chromosomes. So in genetics, genetics is a medical science that's concerned with the transmission of characteristics from parent to child. We have cell division. All beings begin as a single cell, which is a zygote. Whenever we have abnormalities of chromosomes, so abnormalities in chromosomes can lead us to having different types of genetic disorders. Now an example is a pair of chromosomes that fail to separate during cell division. This is called non-disjunction. This occurs during meiosis and before fertilization. This fetus will have an abnormal chromosome in every cell, and it may be a trisomy or a monosomy. So we have trisomies that are 47 chromosomes. One pair will have 3 chromosomes instead of 2. We have Down syndrome, which is an example of a trisomy condition. There are 3 chromosomes for the number 21 chromosome. Modes of inheritance. Many diseases are caused by an abnormality of a single gene or a pair of genes. Now, we can have someone where if we have, it'll depend on the chromosome location. But if we have a female with an abnormal recessive gene on one of her X chromosomes, usually they have a gene on the other X chromosome that compensates and it can maintain normal functioning. But if a male is at a disadvantage and it only has one X chromosome and it has an abnormal X chromosome, then the male has no way to compensate for that normal gene because his other chromosome is a Y. A chromosomal disorder affecting only the X chromosome, then that abnormal gene will be expressed in the male because it only has the one X chromosome. It doesn't have one to compensate for it. You can see in your textbook on page 190 of McKinney, you'll see an explanation with a genogram of single gene trait, autosomal dominant inheritance. So autosomal dominant characteristics is when there's a single copy of the gene is enough to produce the trait. So males and females are equally likely to have the trait, and it often appears in every generation of that family. So although a family member having the trait may have widely varying manifestations of it, so different levels of severity, but the gene overshadows the other genes of the pair. Now, characteristically, the affected individual will have a parent who is affected. The affected individual has a 50% chance with each pregnancy of passing on that abnormal trait. Now, examples of these normal traits that we might have are blood groups A and B, or an Rh positive blood factor. Abnormal traits that are autosomal dominant are Huntington's disease and neurofibromatosis. Autosomal recessive disorders, characteristics of them are 2 autosomal recessive genes are required to produce this trait. Males and females are equally likely to have it, and there's often no family history of the disorder before the affected child. If more than one family member is affected, they are usually full siblings. So a close blood relation of parents increases the risk of this disorder. Now, this also means that these disorders are more likely in groups of people who are isolated by geography and may be more common in specific ethnic groups. Transmission of the trait from parent to child. The unaffected parents are carriers if the abnormal autosomal recessive trait. Children of carriers have a 25% chance of receiving both copies of the defective gene and having the disorder. And children of carriers have 50% chance of receiving one copy and being a carrier themselves like their parent. And children of carriers have a 25% chance of receiving both copies of the normal gene. So they are neither carriers nor affected. So these children have a 50% chance of being carriers, but only a 25% chance of having the illness themselves. Examples: normal traits that are autosomal recessive are having the blood type of O and being an Rh negative blood factor. Abnormal traits that are autosomal recessive are Tay-Sachs disease, sickle cell, and cystic fibrosis. Sex-linked inheritance. These you'll see referred to as X-linked or sex-linked. So although these are recessive, only one copy of the gene is needed to cause the disorder in a male, because a male does not have a compensating X chromosome without the trait. So males are affected with rare exceptions. Females are carriers of the trait but are not usually adversely affected, again, because if it's an X-linked disorder, they have two X chromosomes. Affected males are related to one another through carrier females, and affected males do not transmit the trait to their son, again, because it's X-linked. If the man were to produce a son, now examples of this are color blindness and hemophilia A. Multifactorial disorders. Multifactorial disorders are disorders that result from an interaction of genetic and environmental issues. So there's a genetic tendency toward the disorder, and it's modified by the environment. The interaction may influence prenatal and postnatal development. One of those examples is spina bifida. The embryo may have a high risk for spina bifida related to genetics, but may be at a higher risk for spina bifida because of the factors of not having enough folic acid intake. Now, multifactorial disorders have two characteristics that distinguish them from other types of birth defects, and that is that they're typically present and detectable at birth, and they're isolated defects rather than ones that occur with other unrelated abnormalities. A multifactorial defect may cause a secondary defect. An example of that is babies with spina bifida are higher risk for hydrocephalus. That's because of the abnormal development of the spine and spinal cord will disrupt the spinal fluid circulation and allow it to build up in the brain. It can be mild to severe. The more severe the defect, the greater the number of genes present for that defect. We're going to talk about fetal development. Conception occurs in the ampulla of the fallopian tube. The ova are fertile for approximately 24 hours after ovulation. So once ovulation occurs, that egg is sent down the fallopian tube. It's now fertile for 24 hours. The good thing is that sperm are viable for 3 to 5 days. It's believed that they're the most fertile for 24 hours. Now there are 200 to 500 million sperm per ejaculate, and they can reach the fertilization site within 5 minutes. So after intercourse, we know that that sperm will live for 3 to 5 days. So if that ova sends down an egg at any point during those 3 to 5 days, there's a possibility of fertilization. We're going to talk a little bit about twinning, because there are different types of twins. The type of twin that we have can be important for safety during the end of her pregnancy. Now this PowerPoint has a picture of twinning, and what we have in this picture, on the left side of your screen you see that we have an example of monozygotic twinning. The single inner cell mass divides into two inner cell masses during the blastocyst stage. These twins have a single placenta and chorion, but each twin develops in its own amnion, so its own amniotic sac. Now, monozygotic twins are conceived by the union of a single ovum and sperm. So, one egg, one sperm, with a later division into two. So, monozygotic twins are identical genetic complements and are always the same sex. This is what you'll hear people refer to as identical twins. Now, there are different types of monozygotic twins. The monozygotic twin that divides early in gestation, which happens in most cases about 65% of the time, the formed blastocyte has two inner cell masses instead of one. With two inner cell masses, the fetuses have two amnions, which are the inner amniotic membranes, but a single chorion, so a single outer membrane. So we have two twins within one bigger sac that have an inner membrane that separates them. So they're floating in their own amniotic fluid and their own membrane, right? So if the conceptus divides earlier, you have two separate but identical morulas that develop and implant separately. So these monozygotic twins have two amnions, two chorions, and although their placentas develop separately, sometimes they fuse in utero so close together that you can't really tell if it's one. This is something you have to determine after the birth of the babies. Now, if we have a later separation of the inner cell mass, this can result in twins, monozygotic twins, with a single amnion and a single chorion. Now, these twins are at a higher risk of fetal death because their umbilical cords become entangled. Because if you think about it, we've got two twins that are in the same sac with the same amniotic fluid, and they're floating around, and it's very easy for them to get tangled up in when it's only one cord. But now these twins have two cords to get tangled up in. If there's an incomplete separation of the inner cell mass, this is what can result in conjoined twins. Now, on the right, what we have is our dizygotic twins. Dizygotic twins are different altogether. These are what we call fraternal twins. This is because we've had two ova, so two separate eggs, and two separate sperm, which means they're fraternal twins. They're not identical twins. They can be the same sex or they can be different sexes. But they may or may not have the same similar traits because they are not an exact duplicate DNA-wise. What we have is these twins often result from infertility therapy that we do for advancing maternal age, so we're talking about Clomid pregnancies. Dizygotic twins may be they are hereditary in some families. This is because of an inherited tendency for some women to release more than one ovum per cycle. African Americans have 1 in 70 births are dizygotic twins. African women, 1 in 20 births. Caucasians, 1 in 125, and Asian, 1 in 500. Now, the membranes in the placenta of dizygotic twins are completely separate because, again, they arise from two very separate zygotes. We have two pregnancies occurring in utero at the same time. Dizygotic twins are not conjoined. It's not a risk for them. They are also not at risk of getting entangled into each other's cords. Here we can see the journey of the fertilized ovum. The zygote travels through the fallopian tube to the uterus, and it divides into a solid ball of cells which floats for about 2 to 3 days in the uterus. Cell division changes, and this is called blastocysts develop. A blastocyst has an inner cell mass which will become the embryo. The outer becomes the placenta. And here we can see a picture of the prenatal development from fertilization, starting on the left there, into the implantation of our blastocyst. The embryonic phase. So our embryonic phase, we have a rapid cell division and differentiation, and we develop an embryonic membrane and germ layers. The embryonic period is from the 3rd week until the 8th week after conception. The basic structures and organs are completed during this period. Here we see our fetus at we see our fetus at 2 weeks. You can see on page 219 of chapter 12 of McKinney our timetable of prenatal development based on the fertilization age. Embryonic development during week 3. We have a crown rump length, which is something that you'll hear referred to during an ultrasound of 1.5 millimeters. During this time period, we have neural tubes are still open at each end, remembering that neural tube defects are dependent on the time period that that development did not occur correctly. So during this initial embryonic period, it's important for us to get the right amount of folic acid so that those neural tube defects are prevented. Unfortunately, many women do not know that they're pregnant during this embryonic development stage. So it's important to teach women that during their reproductive years, whether they're planning to get pregnant or not, to make sure that they're taking in an adequate amount of folic acid. Now, early development malformations that occur during the pre-embryonic stage seldom result in a viable fetus. So during the pre-embryonic phase, which is at the 2 weeks the period of the embryo begins, if something does not occur correctly, usually that will result in an early miscarriage. Sometimes women don't even recognize that they were pregnant, and they will have a miscarriage and just think that they've had a heavy period. The embryo is very susceptible to teratogenic agents. So during this embryonic phase, we want to protect our babies from exposure to chemical agents that can cause harm. Teratogens are agents in the fetal environment that either cause a birth defect or increase the likelihood of a birth defect. Now, people often ask whether a certain drug or a substance will harm the baby, and we know that there are some definite medications and drugs that are harmful and some that are safe, but for most agents, the potential for causing harm to the fetus is not very clear. There's several things that happen that make it very difficult for us to know 100% if something is safe during this fetal development phase. Part of that is that we don't do research on fetuses and on pregnant moms. So that has limited our controlled studies of moms. What we do have available are retrospective studies, and that's the difficulty in that is that we have to rely on the honesty and the memory of a mother of what substances she ingested or she was exposed to during her pregnancy and the time period. Timing of exposure can be essential, because if it occurs during that early prenatal development, it can be harmful, but sometimes the same agent later on in pregnancy is not harmful. The other thing is sometimes there's non-transferability of animal studies, so the results of animal studies are not always applicable to humans. And teratogens typically cause more than one defect. There are the agents that we know. There are hundreds of individual agents that are either known or suspected teratogens. Maternal infections like viruses and bacteria that cross the placenta can damage the embryo and the fetus during development. We know that there are some therapeutic agents and illicit drugs, tobacco and alcohol, pollutants, chemicals, and other substances that the mother's exposed to in daily life. Ionizing radiation. We know that maternal hyperthermia can cause harm during this embryonic phase. Diabetes and maternal PKU can cause teratogenic effects. So what we want to do is we want to avoid fetal exposure. Some of the ways that we avoid that fetal exposure is, one, we recommend no amount of alcohol intake or illicit drugs during pregnancy. The reason for that is we know that some people have drank alcohol during pregnancy, but we don't know how much alcohol is too much alcohol to damage our fetus. Infections, one of the things we do is that we do a rubella immunization a minimum of 4 weeks before a pregnancy occurs to eliminate the risk of contracting the infection during pregnancy. Contracting the rubella virus during pregnancy can cause severe fetal defects. The way we are treating that now, and is recommended by the Center for Disease Control, is that we give the rubella vaccine if the mom is rubella equivocal after her pregnancy. This ensures we can be sure that she will not become pregnant within the next 4 weeks. Although that is a teaching that we should be doing. Our pharmacology books do outline the risk factors for medications as far as pregnancy and breastfeeding. Maternal hyperthermia, maternal fever should be avoided during illness. Pregnant women should be cautioned to avoid or limit exposure to heat in saunas and hot tubs. Milestones of development. Here's a chart here that outlines the milestones of development. You can see what the highly sensitive periods are and what the less sensitive periods are for different types of defects. The period of the embryo. We know that the first heartbeat is heard at 23 to 24 days of life. This is when the major organ development is initiated. By the end of the embryonic period, the embryo will have human characteristics. Here is our 4-week embryo. The 4-week embryo is C-shaped, and you can see that there's a tail that's visible. This is because the brain and the spinal cord are developing rapidly, but the fetus's size is not quite caught up with that spinal cord yet, so it does appear that our fetus, our little embryo here, has a tail. Embryonic development during the 4th week. Again, page 219 will outline our different changes. Our week 4, we expect our crown rump length to be 4 millimeters. The neural tube is closed at each end, and eye development begins as there's an outgrowth of the brain. Here is during this time period when the heart is beginning to partition off into the 4 chambers and begins beating. Here is our 6-week fetus. Our 6-week fetus is 13 millimeters in crown rump length. There's a development of the pituitary glands and the cranial nerves. You will notice that the head is sharply flexed and there's rapid brain growth during this time period. So we see that compared to the body, we have a rather large head on our fetus. Here's our 8-week fetus. Our 8-week fetus is approximately 30 millimeters crown rump length. Our spinal cord will stop at the end of the vertebral column, so now our fetus no longer has a tail. Interestingly, we have eyelids now, but our eyelids are fused shut, and our taste buds are beginning to develop. The ears look kind of low set, but they are formed, and our heartbeat is detectable on ultrasound. Now, if you look very closely, you can see the Wharton's jelly in the umbilical cord here, and you can see that the intestines are still located in that umbilical cord. The fingers and toes are still webbed, but are distinct, and we do know that the bones are beginning to ossify, so the joints are starting to resemble those that they will have as adults. 14 weeks. We have our 14-week fetus here, which generally the crown rump length will vary as they start to get older, but we would expect our crown rump length to be right around 100 millimeters. Between that 12th and 16th week, the face is starting to look human-like, and the eyes face forward rather than to the side. Our pulmonary vascular system is developing rapidly, and now our fetus at 16 weeks has begun to swallow amniotic fluid and produce meconium, which is what will be contained in the bowels until delivery. Hopefully. We'll talk a little bit more about meconium when we talk about the labor and delivery process. Our urine is being excreted into the amniotic fluid, so our amniotic fluid will begin to develop rapidly and build up. The major organs have developed at this point, and our refining of functioning will occur until delivery. The fetal stage will extend from the 9th week until delivery. Now, by 13 to 16 weeks, the mom may experience fetal movement. So sometimes it's called quickening or fluttering. Here we have a diagram of the fetal circulation, which we did talk about before, but you'll want to review again. The fetal stage. So lip movements indicate the development of a sucking reflex. So even during this fetal stage, if an ultrasound's done, you can see the infant sucking on their thumb. They begin to swallow, again, their amniotic fluid, and the lanugo is developed. 17 to 20 weeks, the alveoli and the lungs are developing. And now we'll notice a primitive respiratory movement. So on ultrasound, they will be able to note respiratory and lung movements. Our fetus is developing brown fat, which again, if you think back to last week, brown fat is very important. So the more brown fat we develop, the better our infants will be at maintaining their temperature and their glycemic index. Vernix develops and is initiated. The importance of vernix is it's a white, cheesy-like coating. It covers the skin, and this is what protects our baby's gentle skin from the amniotic fluid, remembering that we've got a baby who's going to be floating in amniotic fluid for about 40 weeks. So that vernix will protect their skin. and they're able to store iron. 21 to 24 weeks. Already at 21 to 24 weeks, our babies will exhibit a startle reflex. They respond to sound at 24 weeks, and by 24 weeks, the surfactant has developed to facilitate some expansion of the alveoli. Respiratory movements may occur at delivery. Minimal gas exchange is possible, and they have very little subcutaneous fat. Newborns born between 21 to 24 weeks will suffer from many disabilities. Survival is less likely during that 21 to 24 week period, and they are at risk for major permanent disabilities. 25 to 29 weeks. During this time, the fetus will assume the head down position. Their heads are heavier than their bodies, so gravity will take their heads down and get them hopefully into place in a vertex position. Cephalic down. Surfactant is present. Now, these babies, if they're born between 25 and 29 weeks, are at a high risk for respiratory distress syndrome. This occurs because of the inability to maintain respiratory effort. Erythropoiesis begins in the bone marrow, and now the testes will descend into the scrotal sac. In females, the clitoris is prominent and the labia majora is small, and the adipose begins to develop. Here we can see our 28-week fetus. We can see the large vein and the two arteries there in the umbilical cord. Now the clear white part of that umbilical cord is called the Wharton's jelly, which we are going to talk about. 30 to 34 weeks. Now our fetus is gaining weight from an increase in muscle and fat. The lungs are not fully developed, but the fetus is able to survive extrauterine life. Now the scrotal sac has a few rugae on it. Skin is less wrinkled and it has a more filled out appearance. And the pinna of the ear is still folded and flat. That 30 to 34 week period, these babies are born during this time have a good chance of survival, but will still probably need to stay in the NICU for a few weeks. 35 to 38 weeks, the LS ratio is greater than 2 to 1 by 35 weeks. The clitoris is covered and the labia majora increases in size. And now our lanugo is disappearing. At 35 to 38 weeks, our fetus will have a firm hand grasp. It'll begin to orient to light. 39 to 40 weeks, our testes are palpable in the inguinal canal. The labia majora are well developed, and vernix is still present, but you'll still find it in the creases and the folds of the skin. Now, once babies reach this 39 to 42 week time period, we're going to notice, because that vernix is gone, is no longer protecting their skin, is when we're going to notice they're going to have the more dried out, peely, flaky skin. The chest is prominent and slightly smaller than the head. Our mammary glands protrude in both sexes, and lanugo sometimes still remains on the shoulders and back. Placental development. So your placenta is an amazing temporary organ that provides fetal respiration. This is what maintains the metabolic and nutrient exchange between maternal and fetal circulation. The outer layer of the blastocyte is called the trophoblast and develops into the placenta. The chorionic villi develop between 9th and the 25th day. The villi in contact with the endometrium is called the decidua. This becomes the anchoring villi. Here you can see a diagram of the placenta, and you can see the red represents the high oxygen content and the blue the lower oxygen content. And you can see the blue vein and the two red arteries. Placenta functions to exchange gases and nutrients. At term, the placenta is round, flat, and usually 1/6 the weight of the baby. If the baby were to deliver preterm, initially the placenta is larger than the baby, and as the baby rapidly increases in size, the placenta will not increase in size as quickly. The maternal surface arises from the endometrium in the uterus. It's called the decidua. When we see a placenta after delivery, that is the rougher, meatier looking side of the placenta. The fetal surface develops from the chorionic villi. Now this side of the membrane will be smooth, shiny, and white. Hopefully in your Across the Lifespan clinical, you'll have the opportunity to see a placenta and see the difference of that maternal surface and that chorionic villi, that fetal surface. Maternal placental circulation. Oxygenated blood enters the intervillous space from the decidual bacillus. Maternal blood pressure does directly affect the blood that goes towards the chorionic villi. That's what makes maintaining that maternal blood pressure so important. Again, another thing that we'll talk more about when we come to our labor and delivery portion of this course. The fetal placental circulation, deoxygenated blood leaves the fetus through the 2 umbilical arteries, and the oxygenated blood is carried to the fetus from the umbilical vein. Here you can see a picture of the fetal circulatory circuit. That is on page 229 of McKinney. Some of the things to kind of note is we see the fetal circulation. We have the 3 shunts, the venous ductus venosus, the ductus arteriosus, and the foramen ovale. They allow most of the blood from the placenta to bypass the fetal lungs and the liver. Now, when we look at our circulation after birth, do note that the fetal shunts have closed, and the umbilical vessels, the ductus venosus and the ductus arteriosus, have been converted to ligaments. Placental functions. Respiration. So oxygen in maternal blood crosses the placental membrane, and this is what takes the place of respiration that would occur from the fetal lungs. Now we also get nutrition, so water, salts, carbohydrates, fats, proteins, and vitamins cross the maternal blood. The placenta also metabolizes glucose and stores glycogen. Excretion includes the waste crosses the placental membrane. It also protects from and prevents the transfer of many harmful substances from the maternal circulation, and we store carbohydrates, proteins, calcium, and iron. Hormonal production. So the placenta produces many hormones necessary for normal pregnancy. HCG causes the corpus luteum to persist and to secrete estrogen and progesterone during the first 6 to 8 weeks. That overproduction of estrogen and progesterone is what causes the maternal nausea and vomiting during that early part of pregnancy. Now, the HCG is also what causes that Y chromosome. When the Y chromosome is present in a male fetus, the HCG causes the fetal testes to secrete testosterone necessary for normal development of those male reproductive structures. Now, the human chorionic somatomammatropin, which was formerly called the human placental lactogen, which you'll see here as the HPL, that promotes the normal nutrition and growth of the fetus, and maternal breasts are prepared for lactation. So that HPL hormone is quite important if the mom is planning to breastfeed. The hormone also decreases the maternal insulin sensitivity, which makes glucose available for fetal growth. Now, estrogen and progesterone are what we call steroid hormones. The estrogens cause the enlargement of the woman's uterus, enlargement of the breasts, and growth of the ductal system of the breasts. So it also causes the enlargement of the external genitalia. Estrogen enhances uterine activity. So as she becomes full term, it plays a role as labor will begin. Progesterone causes the endometrium to change into decidua, which provides the nourishment for that placental formation. The progesterone reduces uterine contraction and suppresses maternal reaction to fetal antigen and prevents spontaneous abortions. So it's that progesterone that is so important in keeping that uterus calm and not allowing it to contract and deliver that fetus preterm. That's why patients who have a past history of preterm deliveries are sometimes given a progesterone supplement to keep that uterus calm. They're still doing research to see if that has been an effective intervention, but right now it is a standard of care. Budding of the alveoli that will secrete milk, and development of the secretory characteristics in the alveolar cells. Other hormones that are produced by the placenta include the human chorionic thyrotropin and the adrenocorticotropin. These are growth factors. The umbilical cord. This is the connecting link between the fetus and the placenta. Again, we've talked about it, but it has one large vein, 2 smaller arteries. That's something that we're looking for after each and every delivery. The umbilical vein carries oxygenated blood to the fetus. The umbilical arteries will carry the deoxygenated blood to the placenta. It's composed of Wharton's jelly, which is, again, a connective tissue that prevents compression of the umbilical cord in utero. Amniotic fluid. So this is pale straw-colored fluid in which the fetus floats in. It's produced by the amniotic membrane covering the placenta. Now there are two membranes. That's not something that everybody realizes. We have the amnion and the chorion. So that amnion is the inner membrane. The chorion is the outer membrane. They are so close together that you can hardly tell that there's actually two there. But together we call them the bag of waters. So they can be separated. If they rupture in labor, they usually rupture together and causes the rupture of membranes. Now, amniotic fluid is derived from two sources. This is important to know because we can identify problems in the pregnancy just by the amount of amniotic fluid she has. Fetal urine and fluid transported from the maternal blood are what make up the amniotic fluid. Now, what we will see in the amniotic fluid is we'll see epithelial cells from the fetus and vernix that are floating in it. If the fetus passes meconium, we'll also see a green-colored amniotic fluid from meconium. Now, some amniotic fluid is absorbed by the fetal lungs with breathing movements, and then additional amniotic fluid is swallowed and absorbed into the fetal GI tract. That's what makes the meconium. The volume of amniotic fluid increases throughout pregnancy until it reaches about 500 to 1,000 mLs at term. This varies in the last trimester. The one thing we do know is that if we have an abnormally small amount of amniotic fluid, so if we have less than 500 mLs of amniotic fluid, it's called oligohydramnios. This is associated with poor fetal lung development and malformations that will result from compression of fetal parts. That's because we know that fetal lung development, we can identify that there's a problem with the kidneys failing to develop, so urine excretion is blocked, or the placental blood flow is not adequate. So these are the problems that we know could be going on if we have oligohydramnios. The reason why defects from compression of fetal parts occur is because if there's not enough amniotic fluid in there, all those fetal parts are going to be squashed to one side. They're not freely floating in the amniotic fluid. Then we have the opposite problem. We have hydramnios or polyhydramnios. The quantity may exceed 2,000 mLs. Hydramnios occurs when the fetus has a severe malformation of the central nervous system, or the gastrointestinal tract prevents normal ingestion of amniotic fluid. So in that case, the fetus isn't taking the fluid in, but your body, the maternal circulation continues to provide more amniotic fluid, but the infant isn't utilizing it the way it should. So more fluid builds up than it has to. Again, in the week that we talk about labor and delivery, we'll talk about what those risk factors are, because both polyhydramnios and oligohydramnios put our infants at risk. Function of amniotic fluid, it's a medium for movement. So as long as we have a lot of amniotic fluid and there are babies floating around is happy, the umbilical cord's floating in the amniotic fluid. If we don't have enough fluid, we might have that cord pressed against the baby's hip, arm, leg. Now, the amniotic fluid also protects from injury from external causes. So if mom slips and falls, she's in a car accident, it can prevent us from damaging that fetus. That's our body's way of protecting our baby. Maintains temperature. So we want to maintain a normal temperature in utero. The amniotic fluid stays at the maternal temperature, which means if mom has a fever, the amniotic fluid temperature goes up. We can often see that mom is getting a temperature by the baby's fetal heart rate before we even see the temperature go up maternally. So sometimes what we'll see is we'll see a fetal tachycardia. Now, having too much amniotic fluid will overdistend the amniotic sac. If we have the right amount, that 500 to 1,000 mLs of amniotic fluid, it distends the amniotic sac, giving us room for our fetus to grow. It prevents the amnion from adhering to the fetus. So if we didn't have a lot of amniotic fluid in there, that amniotic fluid sac might adhere to our fetal parts. Maybe an important factor in dilating the cervix. One of the things that happens is as that amniotic fluid, that bag of amniotic fluid gets bigger and heavier, it puts pressure on the cervix.